Hi, Assalamualaikum and good morning. Thank you, Dr. Azrin and NRAS faculty for the invitation and opportunity to share on IHH experience in improving post-operative outcomes through regional anesthesia. So today I'll be focusing on how RA has supported better pain control and early recovery in ACL patients, but most not in clinical perspective, but more on the operation perspective. Despite clinical advancement, many patients still report moderate to severe post-op pain, and this delayed recovery, mobilization, increased opioid reliance, and prolonged hospital stay, all of which reduce patient satisfaction and recovery outcome. And yet, while RA is well established in literature for effective pain control, however, in practices, its usage across hospital remain inconsistent. And there's a gap between evidence and application. And that's the area for improvement for us. And this echo with our data. Around 5% of prolonged stay across our hospital are directly related to uncontrolled post-operative pain. And these delay early mobilization, which typically starts only at post-op day 2. And as a result, only 60% of our patients are discharged within 3 days of admission. And in terms of recovery, while 86% of patients achieve functional recovery within 3 months, the pain improvement remained inconsistent. As shown in the chart on the right, some patients even reported no improvement or worsening pain despite meeting physical recovery milestone. This made us revisit our aim by reflecting on what truly matters to patients and realign our goal accordingly. So we focus on improving 3 key clinical indicators: the pain score post-surgery, rehabilitation pre and post-surgery, and readmission rate. To understand the patient perspective, we use a structured survey called IKDC scoring system, which specifically measures pain, functional improvement, and quality of life. And from a cost perspective, we track key drivers like length of stay, average bill size, to help us evaluate whether improved outcomes will also deliver greater cost efficiency. And with this, we build on the key focus area. We took a structured approach for implementation. We start by laying a foundation, appointing clinician leads, including Dr. Sharidan, Dr. Bay, one of it, and we develop guidelines on peripheral nerve block and standardized rehabilitation protocol. And all key clinical indicators were embedded into our care pathway from the start. Next was our operational setup. How do we do this? We need a full multidisciplinary commitment, so we engage with all the key stakeholders involved in the arthroplasty surgery, the surgeon, anesthetists, and physiotherapists to align on the clinical goal. And at the same time, we focus on managing patient expectation through structure, education, and prehabilitation. With this element in place, execution phase become much smoother. We focus on continuous monitoring of pain scores, RA usage, rehab progress, and discharge outcome. To ensure long-term success, we embedded regular audit cycle, feedback loops, and create a learning platform where doctors can share outcome, discuss outliers, and drive ongoing improvement together. And here is one of the snapshot that for our guidelines that we have developed. This to ensure that blocks are practiced safely, consistently, and effectively. This was collaborated effort led by clinicians, Dr. Sharidan, Dr. Aizad, and also supported by our clinical governance and advisory committee chairman, Dr. Lai. And this guideline outlined that entire perioperative pain strategy starting from pre-operative assessment, intraoperative RA protocols, and to post-op analgesia, as well as when to start the early embolization. For example, in these guidelines for arthroscopy, we recommended GA with a ductal canal block supported by multimodal analgesia. Importantly, this document also standardized practices such as early embolization when pain is well controlled. The intent here is not just to protocolization, but to ensure every anesthetist can perform this block with confidence and patient receives safe and optimized pain management. And to further strengthen the safe and confident practice in our anaesthetists, we organized the first IHH Malaysia Regional Anaesthesia Workshop in June 2024. This was our first multidisciplinary platform involving 16 of our hospitals, bringing together anaesthetists and orthopedic surgeons from across our hospital with a shared goal, improving outcome in arthroscopy surgery. And here, as shared, is the workshop picture that we have done. From here, what I want to tell is that it wasn't just about the training or the technique. It's the part of it, but the most important thing that what we learned from this is this session built mutual understanding from surgeon and anesthetist part. And one most impactful session was a hands-on block placement training. And with this, the surgeon gained confidence in RA and allowed the anesthetist to practice for their patient. And the outcome speaks for themselves. And from the chart, we can see that with all the strategic implementation from guideline development to multidisciplinary engagement, we achieve progressive adoption across IHH hospital. Today, 50% of our hospital have adopted blocks for ACL surgeries. And from a clinical utilization perspective, 1 in every 3 ACL procedure is now performed with the regional blocks. And this reflects not only growing confidence among anesthetists, but also strong collaboration across specialties. And most importantly, better care for our patients. From the data we collected, it's clear that cases performed with block demonstrate more effective pain control compared to those without. Not only do we see lower pain score, but there also less variability in the outcomes, meaning patients are recovering more consistently when blocks are used. And we also saw improvement following the implementation of a rehab together with the RA. More and more patients are going home within 3 days of admission, a clear indication of better pain control and early mobilization. And when we compared patient experience in terms of pain at 3 months of recovery, the difference between 2023 and 2024 is clear. In 2023, we still have several patients who reported no improvement or even worsening pain at 3 post-op, as seen by the data points below the rate. However, in 2024, after implementing structured care pathway, 100% of our patients showed improvement in their recovery. And beyond clinical outcome, we also seen the positive shift in the cost efficiency. While this is still a journey, the improvement we've made from streamlined processes to better patient outcome, the cost impact are starting to show improvement. Specifically, cases using block recorded a 6% reduction in average bill size compared to non-block cases. And this cost saving is largely driven by shorter length of stay and reduced pain medication usage. So what's next? Moving forward, we aim to expand this initiative across more hospitals within IHH network. I'm also looking to adapt the same RA-driven approach to other procedures where pain control is critical: breast cancer surgery, C-section, TKR, and also CABG. And a key focus going forward to be the continued hands-on training and workshop, ensuring that anesthetists across our network are equipped, confident, and supported to lead the change in perioperative pain management. The relationship between improving clinical outcomes and healthcare policy is complex, but it's generally understood that policies can significantly influence clinical outcomes, either positively or negatively. When outcomes such as pain control, early discharge, and recovery rate improve, it strengthens the case for broader adoption and policy level change. Second, strong clinical data support advocacy. Demonstrating consistent improvement in recovery and cost efficiency give decisions maker the evidence needed to support scaling and resource allocation. And third, policy influence care delivery and access to healthcare, whether in the availability of RA, access to ultrasound equipment, or rehabilitation support. And before I end my presentation, I would like to share a video from this initiative itself, which was recently shortlisted by Value-Based Healthcare Europe alongside submission from 5 other international countries. And this video truly resonates with the collaboration effort of the anesthetists, surgeon and physiotherapists in making RA possible. Thank you.